Well, thank you so much for the introduction. All right. Well, very quickly, I'm a clinical psychologist and an associate professor at the School of Professional Psychology at Wright State University. And I've been working in the area of neurodevelopmental disabilities and specifically, for the last probably 10, 15 years on fetal alcohol spectrum disorders or prenatal alcohol and drug exposure. So I have so many things, and I think I got very zealous and put a lot of information in here. So I'll mind our time and for the case discussion and so forth, and try to kind of give you kind of like a quick summary of what I'd like to talk about today. All right, let me try to. Okay, well, first of all, happy Halloween, everyone, and I'm glad we discuss our candies too. So enjoy your weekend with the Halloween if you are doing it with your family and children and so forth. So I'd like to talk a little bit about the impact of alcohol on the unborn baby, and then identify symptoms and red flags of fetal alcohol spectrum disorders, and a little bit touch on the differential diagnosis of FASD with other neurodevelopmental disorders. First of all, I'd like to
I'm so sorry to interrupt. It looks like we can't see your slides.
Oh, okay. I'm sorry. Not sure what happened here.
I was giving you a moment because I wasn't sure. I'm like, maybe she's going to pull them up.
I thought they were up. Maybe with the transitions, they just did not. Okay, I'll try again.
It looks like they're coming. And we see the present if you just go from beginning.
Sure. Yeah. How about now?
Perfect. Thank you.
Okay.
Sorry to interrupt.
About that. I think with I had it up before, and with the transition, maybe they just went away or something like that. Okay. Yeah. We're going back to my happy Halloween again. And so our objectives is to identify the impact of alcohol on the unborn baby, identify and understand some of the red flags, and talk a little bit about the differential diagnosis, so differentiate it from other neurodevelopmental disorders. So fetal alcohol spectrum disorders, when we say FASD, this is not a diagnostic term. This is an umbrella term to describe all disorders that happen as a result of prenatal alcohol exposure. And I'm going to talk about the different parts of it, but I'm not going to go into the details of the diagnosis, which could be a whole another didactic. But what we know is that FASD is the most common leading cause of preventable intellectual disability or cognitive impairment or developmental delays and birth defects in the United States. And it happens when there is prenatal alcohol exposure during pregnancy. When we don't have that, then we do not have FASD. So alcohol is a teratogen, and compared to, I get that question a lot, compared to smoking, drugs, alcohol, which one is the most harmful? Well, alcohol is the most harmful teratogen because it passes through the placenta, and it passes through the blood-brain barrier and impacts the organization of the brain before the brain is fully developed. So I just wanted to highlight definitely that part. So I don't know if I can ask some questions, but I really wanted to see maybe a couple of responses, if you wouldn't mind maybe either put in the chat or just saying it. But as far as autism prevalence, do you know what the prevalence for autism is? Any thoughts? And I know we all work in different capacities with different neurodevelopmental disorders. Thoughts? I'm gonna put the chat too, but right, I think just for time purposes, I'll just throw it out there. So it's 1 in 54, so that makes it 1.85%. So when we think about autism, we hear it all the time, it's everywhere. And then when we think about ADHD prevalence is 2.8%. So now I'm going to give you the statistics, which is mind-blowing, because the latest research by May et al. In 2018 indicates that FASD prevalence is 2 to 5%. That is highly prevalent, and therefore it is a significant public health concern. But then we might say, like, well, we know all the other disorders. How come we don't know as much about FASD? Maybe not this group, but just in general, lay people, if you ask them on the street, what is FASD or what is autism, they would likely know something about autism or ADHD, but not at all about FASD. So we are lacking behind in terms of our research, in terms of our awareness spreading, and in terms of the clinicians knowing things about FASD. Trying to advance the slides. Okay. So in terms of, sometimes I get this question, my OBGYN told me that I can have a glass of wine in the last trimester to kind of like relax and so forth. So we got all of this faulty information around because at this point, there is no research that indicates that there is a safe amount of alcohol consumption during pregnancy. So when there is alcohol consumption, there's always going to be some impact on the undeveloped baby's brain. Therefore, the pattern and quantity and the timing of alcohol exposure is really important. But we cannot say, because all of our studies are on animal studies, we cannot work with pregnant women. We cannot put them in different groups and ask them to do different things. Therefore, every amount of alcohol will produce some symptoms on the spectrum for FASD. We just might not know how much of an impact there is, but there will definitely be an impact because it's a teratogen and it disrupts and damages the brain. So if a woman drinks during the first trimester, then what we see is the facial features that I will be talking about. If a woman drinks heavily during the first trimester, second and third, and especially in the third, where there is rapid brain development, then what we see is neurocognitive impairments that I will be talking about. So the message should be that there is no safe amount of alcohol during pregnancy period. And then of course, some women will not figure out that they're pregnant until they are, 5 weeks, 6 weeks, 7, 8, and some women till the end of the first trimester. So the best practice is whenever they figure out, and then just to stop. And then if we find that they are consuming alcohol, and then referring them using a lot of different techniques like the Iceberg or motivational interviewing to refer them to clinicians and to professionals where they can work with them on their substance use to stop. So anytime they can stop, we can decrease the impact on the unborn baby. So it's an umbrella term because it has so many different diagnoses underneath each. And then as you can see, I sometimes use this iceberg analogy there, because what we see at the top is children who have the facial features, but that's only a small portion of the FASD spectrum. A lot of the kids don't have the facial features, so they'll be walking around and we will not recognize them. Therefore, they have a lot of functional deficits that we might not be aware of, and they have probably something called the RAND, which I will talk about, but not the facial features, or they will not have the growth difficulties issues. So if you look under the table there, then we can see 4 of the different diagnoses that are under the FASD umbrella and spectrum. So we can have the full-blown FAS, which we call fetal alcohol syndrome, where we have growth deficiencies. Growth deficiencies mean head circumference, like microcephaly, the head circumference below 10th percentile, growth and height below 10th percentile at any time in their life. It doesn't have to be now because they might be maybe adopted and now they are thriving, but sometime in their past there is failure to thrive. And then they have a smaller brain due to the impact of alcohol on the brain because it shrinks the brain. And then we have facial anomalies for the full-blown, which I'll talk about as well. And then we have neurocognitive difficulties. When a child has all 3 of them, and of course, prenatal alcohol exposure is the given, because if we don't have alcohol exposure, we don't have anything under this umbrella. Then we have partial FAS, where we have also, we don't have the growth issues, but we have some of the facial features, we have exposure, of course, and we have neurocognitive issues. So it's kind of like a little milder version. And then the one that we diagnose the most is alcohol-related neurodevelopmental disorder, where we don't have the growth issues, we don't have the facial features, they are growing well, but then the mother probably drank a lot more during the 3rd trimester, where we see a lot of the impairments of neurocognitive impairments. So the one on my right, the one that's smaller, those are 2 deceased infant brains, is the one with FASD. So as you can see, alcohol shrinks the brain cells. So therefore, the brain is much, much smaller. And then the one on the left is a baby who died of SIDS. So as you can see, we see less of the ridges, we see less of the connections. The whole volume is decreased due to the impact of alcohol. So without going too much on the specifics, what I wanted to tell you and share with you is that alcohol impacts the midline of the brain. So everything that's in the middle of the brain. That's why we also see the facial features being impacted, like the nose and all of those, which I'll talk about. So we have frontal lobe here where it's responsible for planning and organization and decision making. We have corpus callosum, which helps us to communicate between the left and the right hemisphere. Then we have hippocampus, which gets a huge hit with alcohol, and hippocampus is the memory hub. So a lot of the time, children with FASD have tremendous difficulties with memory and remembering things. Then we have hypothalamus that gets impacted, which is a hub for self-regulation. Kids with FASD are very dysregulated. They have a hard time soothing and settling down. Then we have cerebellum that's impacted, which is at the hindbrain, back part of our brain, that kind of helps us with our balance. So we see a lot of incoordination, clumsiness, accidents, and being prone to those. Then we have amygdala that's impacted by alcohol, which is a hub for emotional regulation. So these kids have a lot of time, a very difficult time with emotional regulation. They're usually very dysregulated, which then we could diagnose them with some other mood disorders based on that. And then we have basal ganglia that's impacted, which kind of helps us with coordinated movements so that they have fine motor and gross motor difficulties as a result of those. So now when we look at the facial features, then we see a smaller head circumference, then we see these epicanthal folds, and then we have a flat midface, so there is no like cheekbones, and then the nose bridge, the low nasal nose bridge, so when you do that, there is no bump or anything. And then we have the smooth philtrum. Philtrum is the area, if you all do this, there is like this bump that going up in our lip area between the nose and the lip. Okay, so that area is very much smoothed down. So the whole mid part of the face is almost like smoothed down based on the impact of the alcohol on the child. So these are some of the characteristics. This evaluation is done by genetics or developmental pediatrician. I cannot do that. I don't have expertise to do that, but I refer out to genetics to get this done. So for the growth part, any doctor, any pediatrician, physician can look at the growth impairments and diagnose that. Facial anomalies are diagnosed by genetics department or developmental pediatrics. And then the neurocognitive self-regulation part is diagnosed by a neuropsychologist or a clinical psychologist like myself who, or a school psychologist who specializes in neuropsychology, who will be able to do a neuropsychological evaluation to see the impact of all of these functions in the brain and how they are impacted. So in terms of some of the red flags in infancy, so these are the children that we will see that they are very withdrawn. They are not responsive to their parents. When they look or smile, they don't. They start out kind of like very flat. Sometimes we might even think they might have autism from early on. So they don't suckle well and they just have feeding issues. That's why there is like failure to thrive. They have poor sleeping patterns and they start having some language delays like cooing, babbling, all of those kind of like really late in that early infancy. So you might say, well, these look like any other neurodevelopmental disorders, and you are right. And because of that, at that very early 0 to 1, we don't do a good job of diagnosing at this stage. So all we can do is identify the developmental delays, provide early intervention, get them almost ready to grow into these deficits so that we can hopefully catch them around 3 or 4. In toddlerhood, then we see more issues. Now, this is the time we see a lot of memory difficulties. This is when they start learning about their colors, shapes, and all of those concepts. And then all of a sudden, we have parents or teachers saying that, well, I taught them already, and then they just don't remember it. So what's going on? Why can't? So then we think about more learning disability, but that's not a learning disability. That's more of a memory issue. So we have really nice tests to be able to test out their memory to see if it's up to par or not. We also see a lot of hyperactivity. So for our typical ADHD kiddos, then we would see hyperactivity more around 4 or 5. I'll tell you, for this population, the hyperactivity will be like full blown at age 2. So these are the ones that you're going to see. I had 2 clients, one at age 3 managed to climb up the roof, and then another one around that age again went down the rails in the daycare, and just they have that lack of fear. They have hard time associating behaviors and their consequences. Cause and effect. Cause and effect is a very much of a frontal lobe activity. And because frontal lobe is very much impacted, then they have hard time making sound decisions. So that starts on very, very early on. And a lot of aggressive behaviors, but that's not malicious. And the behaviors and those are not, willful type of things. So also what we hear from the parents is that I've tried timeout, I tried, positive reinforcement, nothing has worked. So if you have a parent who has come to you, and they could be adoptive parents, because 70% of these kids end up in the system and then they get adopted, or they're in foster care because the home environment might not be suitable and they might have been removed. So there's a high incidence of children with FASD, and that's one of the red flags in foster care or in the system. When they become children, then we start seeing inattention, and that's when they get diagnosed with ADHD, because now we have the hyperactivity, we have the inattention, they can't learn. So we see more of a diagnosis of ODD, ADHD, and a learning disability all at once. And then if it's not suspected, then that's how they kind of move along. So now we see more fine motor and gross motor issues, a lot of problems with telling time and using money, because they have specific issues with math. There is a high incidence of math learning disability. And they also are very, very dysregulated, tremendously dysregulated, and they have really hard time calming themselves down. Their tantrums last really, really long, like from half an hour to an hour. And now we start seeing problems with adaptive skills. They are behind. And this is despite the fact that they might have a normal or typical average IQ. So we have the IQ here, adaptive skills here, similar to maybe some higher functioning autistic kids. Okay? So that could be another flag there as well. They act less mature than their age. In adolescence, now we see social issues climbing up, and then their self-esteem goes down because now they understand they might be different from others. So they might be very naive and gullible, very easily manipulated into situations where another teen who picks up on their difficulties might tell them like, oh, let's get this. I had this one client where they stole things from a teacher's desk. And then when asked about it, they said, oh, my friend said that it would be fun. And then I didn't think that the teacher would mind, but that we're talking about a teen, and this is a teen with average IQ. So that's not what we expect. And there is no malicious intent. So these impact, of course, school performance and peer relationships. And this is also the time 70% of them get into trouble with law. So there is a huge intersection with the legal system, which they need to have like that safety training that we talked about last time. And then we sometimes see that promiscuity, and then we need to have a lot of that sexual education. We see some secondary issues like now onset of depression and anxiety. And this is a time where a lot of them get diagnosed with bipolar wrongly, and that's not bipolar. So trouble with the law, sexual promiscuity, and then drug and alcohol use also come around. And in adulthood, we see a lot of problems with, remember I said they have problems with managing money. That's a huge thing. They need a lot of help with that, maintaining employment, and then trouble with the law, and those and substance use, they do continue. So the last part I'd like to talk about, and I'm not sure I'm able to go all of them because I know looking at my time, is the overlap with other neurodevelopmental disorders. Half of them do get diagnosed with ADHD. Almost half of them get diagnosed with ID, but then that means half of them don't have ID. And communication disorders, learning disabilities, conduct and oppositional disorders are pretty prevalent. So I did this to kind of like over, especially for ADHD, maybe I'll just do ADHD and ASD and then see, look at our time. I could just put other neurodevelopmental disabilities for us to differentiate as well. But the shared concepts are executive functioning skills, planning, organization, same with ADHD. They have also problems with sustained attention and working memory. So remembering what was told to us. But how we can differentiate ADHD and FASD is that children with FASD have much pronounced self-regulation issues. kids with ADHD have as well, but it's so much more severe. And then children with FASD have a lot more social related issues. So kids with ADHD, you know, they could bother others, they could be like impulsive and so forth, but they do understand the social cues when they pay attention and listen, okay? And then kids with FASD have more, gross and fine motor delays and difficulties and more visual motor integration. So that's an area we also need to test. And then with ASD, they both struggle socially, but the nature of the social related issues are different. In ASD, they do not approach other kids as readily. And if they do, they have a hard time with understanding social cues. It's the same with FASD, but kids with FASD are very friendly. They are actually indiscriminately friendly. They're overly friendly. They might go sit on a stranger's lap, or if somebody tells them to do something, they might go along with that. They readily initiate social interaction. They understand nonverbal cues much better, and they share affect. They, smile. They kind of like direct their gestures. They use gestures and things like that. So those are the ways that we can differentiate. And then the last, I think, piece is because this gets misdiagnosed so much is between conduct, ODD, and then FASD, because in FASD, there's a lot of disruptive behaviors. They both engage in aggressive behaviors and disobedience and noncompliance. But kids with FASD, they are less mature than their age compared to ODD. They engage less in cruelty, bullying, and stealing. And then the triggers for their outbursts is related to dysregulation, not understanding the consequences of their behaviors, and not understanding, and then sensory issues. Whereas the triggers for ODD are not getting their way, not wanting to comply, or wanting to get out of a situation. And then the last piece for the learning disabilities is that we see both math-related or reading-related disabilities, learning issues in both of the disorders. However, in FASD, the math difficulties are so much pronounced. They are mostly impaired, within the impaired range. And then they also have less developed metacognition, which is they don't know what they don't know. They don't know what they know. However, kids with just specific learning disabilities, they are aware of their difficulties, and then they work towards kind of like remediating them. So those are some of the things that could help us out. All right, I'll just stop here. The rest of my slides were just like, well, based on all of this differentiation, we want to diagnose early. If they are diagnosed at age 6, then we have so much better prognosis. But unfortunately, currently, the age of diagnosis is 9.8. It's very, very late. So we need to do a much better job at recognizing, understanding the symptoms, a lot more education, so that we can prevent this misdiagnosis, which is 80%. That is really, really huge number. And if we don't, then they could lead to secondary disabilities. But we cannot prevent, once it happens, we cannot take back the primary symptoms, but we can prevent the secondary symptoms from compiling up, especially postnatal trauma. And these kids really have high incidence of trauma. So if we have any suspicions of a mother consumed during pregnancy, we should refer, or if we have evidence, then we should refer. If we see any of the facial features or they were detected, then we refer. And if the child displays any of these neurocognitive characteristics that I mentioned about, then we should refer. All right, sorry, I know I went a little bit above our time, but just wanted to stop here and see if there are any questions.